Good evening. Welcome to current edition of Vijaya Diagnostic Educational Webinar. This clinical radiologic discussion is usually done with the aim to spread the new information and something new which is happening in the field of radiology for medical community and for lay public also. So today's topic is new PET radiopharmaceuticals in oncoimaging. Uh, Oncoimaging is a very, very important subject. And I remember when I was a young person like Mansoor, whenever somebody had cancer, it was almost considered as a death warrant for him and just preparing to die. And on the death certificate, only date needs to be written. But in last 30 to 40 years, a lot of things have changed, and we do have a lot of advancements which have happened in the treatment of these cancers. So this is a very important topic, and we have two very eminent faculty to discuss it. First is Dr. MVT Krishna Mohan. He is currently the senior consultant medical oncologist at Basavatarakam Indo-American Cancer Hospital. He has done his MBBS from AFMC Pune and DNB medicine from NIMS and DM medical oncology also from NIMS. He has got 16 years of experience in the medical oncology. He is associated with a lot of clinical research in many multi-center international trials. And his area of interest is sarcoma, genitourinary cancers, lymphomas, and also he is actively working in the tobacco cessation. So he will be giving us the clinical aspects about this particular topic. And we also have young, dynamic nuclear medicine expert, Dr. Mansoor. Side, here it's gone. Okay, so we have Dr. Mansoor. He is our nuclear medicine consultant in Vijaya Diagnostic. He has done his MBBS from Deccan Medical College and DNB nuclear medicine from Apollo Hospital. Subsequently, he has worked in NIMS and Continental and Care Hospitals. He has also worked in multi-specialty clinic of Bayton, Houston, Texas. I think he will be talking about the nuclear medicine aspect. So first, may I request Dr. Krishna Mohan to give his clinical perspective that when a patient comes to you with a suspected diagnosis of cancer, how do you approach these patients, and when do you decide that a patient needs higher investigation, and when do you send him for PET CT and all those things? So some clinical perspective, Dr. Krishna Mohan.
Sure, sir. So thank you, sir, for this introduction and making me a part of this webinar series. So I will be very brief. At the same time, I will be very clear. The question is, what do you do when a patient with suspected cancer comes to you? So the classical teaching, whatever has been taught to us in MBBS, still holds good. First, take a proper history and then clinical examination. Most of the times when a patient reaches to our hospital, or a person like me, a medical oncologist, there is already a suspicion of cancer which a primary physician has already given a possibility. When they come to us, they will have certain symptoms which are most likely pointing out towards what is the primary diagnosis. Then what we do is, before I ask for a staging investigation, what I do is I first establish a diagnosis. That is the most important thing, because investigations we divide into diagnostic and staging investigations. Diagnostic investigation is very important for us to know the histology. Most probably it will be a biopsy or a flow cytometry or an FNAC in rare instances. When we have a histological diagnosis, we know whether that tumor is likely to be FDG avid or not. So because that is the point for discussion today, because for staging nowadays, everybody is saying that PET CT scan is the gold standard. PET CT scan is, yes, it is a very good investigation, but it may not hold good in all different types of cancers. For example, low-grade tumors are FDG non-avid. So we should be very careful before we ask for that investigation. Similarly, in the gastrointestinal tract, the large bowel and some of the adenocarcinomas, they are non-FDG avid. So we should not jump for a FDG PET CT scan. So the answer to such question is, how do you go about? Number one is physical examination and establish a histological diagnosis and determine whether it is likely to be FDG avid cancer or not. If it is an FDG avid cancer, yes, nowadays with the wide availability, thanks to centers like Vijaya Diagnostics, which made the PET CT scan affordable to wherever it is applicable. It is not that we do it for everyone, but if we want to do, instead of doing a CT, contrast CT of chest, neck, and abdomen, nowadays we can request for a whole body PET CT scan where it has a proven value. That is what we usually do. And then consult the patient about the diagnosis and the stage of the disease, and then subsequently a treatment plan is made. So this is in brief about how we go about doing this staging workup. At the same time, we also sometimes consider requesting for a specialized imaging for the radiopharmaceutical imaging, like some DOTA PET or gallium scan, PSMA PET scan. These things depending on the primary diagnosis. I think Dr. Mansoor will cover all those things in this subsequent presentation. Am I clear, sir?
Yeah, I think that's really useful. How you approach the patient, and when you send the patient to us, what you are expecting. And till now, we had been mostly doing FDG PET scans and all, but now of late, for last few years, we do have some new pharmaceuticals which are very specific in picking up the diagnosis and all that thing. And Dr. Mansoor is going to highlight about all these new developments. Over to you, Dr. Mansoor.
Thank you, sir. Thank you for inviting me to this webinar series. I will be discussing in brief about the newer PET radiopharmaceuticals used in oncoimaging, and these tracers have been in use for the past few years, and they're not very new, but now they are very much available in clinical practice. So this is the first compound that was used in PET imaging, and it is most widely used. And this is fluorodeoxyglucose at the C2 position, where the fluoride has been replaced. Is replaced the hydroxyl group. It is a glucose analog. It is taken up more in cells which have higher metabolic activity, which is the Warburg effect, and it gets trapped in the cell because after phosphorylation, because it cannot take part in further metabolism, and its conversion back to dephosphorylation back to fluorodeoxyglucose is at a very lower rate, so it cannot escape the cell. And it has been used very, very widely in staging and in assessment of treatment response, but it has a lot of limitations also, where we need a normal glucose level in the patient, and there is very high uptake in the brain, which decreases its sensitivity in detection of brain metastasis, and uptake in the myocardium as well, which is variable. And there is brown fat uptake sometimes, and then there is renal excretion, which makes it difficult for detection of any lesion which is in the renal pelvis or the bladder. You have to do extra scanning with diuresis. And then there are several tumors which have very low FDG uptake. And another important point here is that FDG cannot differentiate inflammation from a malignancy. So that aspect of FDG has been used widely in imaging, in non-oncology imaging. Like an example here is the aortoarteritis case. And then there is no SUV cutoff where you can say that this is a cancer or this is an inflammation. And therefore, the role of FDG in imaging has infection and autoimmune diseases is widely increased also. And then FDG uptake is non-specific, that there is an uptake seen in benign lesion. Sometimes, like this case in a fibroadenoma, there's a benign chondroid lesion in the proximal tibia, and fibroids in the uterus sometimes. This also makes it a non-specific tracer. So, and the uptake in these lesions also depends not just on the metabolic activity, but it is interrelated with hypoxia, angiogenesis, and tumor necrosis. So with these concepts, we'll see what the and then before going to the newer tracers, there are some tumors that have increased P glycoprotein expression. Then there are some where there is a wild type of P53 expression. The regular P53 mutation, wherever it's there in the cancers, there is very high FDG uptake. But when there is a wild type of mutation, there the cancer cells, they have very less FDG uptake. And then the adenocarcinomas, as Dr. Krishna Mohan sir was saying, with high mucin content, they have less FDG uptake. And certain cancers that have decreased expression of glucose transporters, they also have very low FDG uptake. And then whenever there is higher uptake in physiological high uptake in the tissues like brain and the myocardium and then the bladder, so whenever there's a lesion in the vicinity of these areas with high FDG uptake, the detection of lesions is the sensitivity of detection of these lesions is decreased. The newer PET tracers that we have, therefore, are that the ones that target the somatostatin receptors, the prostate-specific membrane antigen, the glucagon peptide receptor, and then the newer tracers also target hypoxia, neovascularization, and then there are certain tracers that have that target specific metabolism and enzyme pathways. We'll be seeing them. The ones that are more commonly in use. We'll begin with F-DOPA. F-DOPA is fluorodopa, which is, and this is an example of a neuronal synapse. It is taken up by the presynaptic terminal. And then it undergoes carboxylation, and then it's stored in the secretory vesicle, and this is how the uptake of F-DOPA is there. And there are several other targets, but the most common here that we are concentrating is the F-DOPA, and that is mostly used in imaging of Parkinsonism, where this is a normal uptake in the basal ganglia. When there is a decreased uptake, we can diagnose Parkinsonism. This is a very important indication, and the ones that we use F-DOPA in oncology imaging is that it's also taken up in the chromaffin cells. So whenever there is any tumor like a pheochromocytoma or a neuroendocrine tumor, there is increased uptake of F-DOPA, and this is a whole body image, a normal distribution of F-DOPA. And here are some examples. This is a pheochromocytoma in the right adrenal gland, which shows increased F-DOPA uptake. And this is also a case of pheochromocytoma where the surgery has been done, but still there is a recurrence or a residual pheochromocytoma. And another example of tumors that take high F-DOPA uptake is an insulinoma in the pancreas. And it has a high sensitivity and specificity, and tumors as small as 2 to 10 millimeter are also detected with this scan. F-DOPA is also concentrated in the medullary carcinoma of thyroid, and this is a case of a tumor in the medullary carcinoma thyroid with bilateral neck metastasis, and this patient underwent surgery with bilateral neck dissection, but still the calcitonin level was high, and then the restaging imaging was done, which showed a residual lymph node in the right neck, and we can say that the uptake is very high and very good tumor to background ratio. And F-DOPA has also been used in detection of glioma recurrence. And the higher the grade of the tumor, the more activity. And because there is very less uptake in the gray matter that we see in FDG here, there is very less uptake. The detection of recurrence is easy compared to the FDG scan. And but here, whenever there is a lesion which is extending into the region of the basal ganglia, it becomes difficult to differentiate here where the lesion is ending, whether it's invading the putamen or it's just limited to the globus pallidus. So there can be limitation there. Now coming to gallium labeled tracer, gallium is also a radionuclide with decays by positron emission. It is supplied in a generator, and this generator is the size of a small tiffin box that can be eluted anytime you want in the department. It has a half-life of 68 minutes, and the parent is germanium-68, and the generator has a life of 1 year. The good thing with gallium is that it exists in multiple oxidation states, so you can label it with many compounds, and in-house labeling with the pharmaceuticals can be done. This is the structure of the somatostatin analogs that are labeled to gallium. Here you have the octreotide, and then this is the This compound is the chelator, which is the link between the radionuclide and the peptide, and the isotope is linked to this chelator. So this is the structure how gallium labeled octreotide analogs are, and we can replace this gallium with another isotope which emits beta radiation that can be useful in therapy. So this is the structure of DOTA-TOC, this is DOTA-TATE, and this is DOTA-NOC. And this is a norm. This is the somatostatin receptor with an extracellular N terminal and an intracellular C terminal. And here is where the binding with of the octreotide happens, and then which leads to a series of signaling pathways inside the cell, and then the entire tracer is internalized into the cell also. This is a normal biodistribution of a gallium DOTA peptide scan. You see physiological uptake in the pituitary, the liver, and both adrenal glands, and there is high activity in the spleen with excretion through the renal system. There is increased binding to the renal cortex as well. This is distribution of the different somatostatin receptors that we have in our body, and the DOTA-TATE, TOC, and NOC have affinity to the type 2 receptor. TOC and NOC have affinity to the type 3 receptor also, and NOC has affinity to receptors to type SS, the somatostatin receptor type 2, 3, and also the type 5. Let us see a few examples of the somatostatin receptor PET imaging. This is the duodenal neuroendocrine tumor with metastasis to the liver. You can see that the target to background activity is very high, and the detection is very simple. This is an example of an ileal tumor, neuroendocrine tumor with hepatic metastasis, and there is a retroperitoneal lymph nodal metastasis also. Here is an example of a mesenteric neuroendocrine tumor. You can see that the root of the mesentery, this enhancing lesion encasing the vessels with surrounding mesenteric fat stranding. There was no metastasis detected here. And this is a case of medullary carcinoma thyroid with lymph nodal metastasis, and case of MEN syndrome. You can see bilateral adrenal tumors and tumors in both lobes of the thyroid gland with small foci of calcifications there. And yeah, this is metastasis in the brain. When there is no background activity, the detection of metastasis with these specific radio tracers is very simple. And this is a bronchial carcinoid with hepatic metastasis. And yeah, so it's the same isotope that we've used, the gallium labeled somatostatin analog, octreotide analogs. We can label 177 lutetium to these octreotide analogs, and then that can be used in the therapy as it gets internalized and emits beta radiation from inside the cell and kills the cells. That is called peptide receptor radionuclide therapy. And we can also use an alpha emitter instead of a beta emitter, the 225 actinium, which is far more effective as it has a lesser range inside the tissue. So the damage to the surrounding tissues is less, and it gives a higher radiation inside the cell. This is PRRT therapy. This is the first staging gallium PET scan with which was metastatic tumor, and after one cycle of lutetium therapy, you can see that there is a good response, and there is a phase 3 trial, clinical trial with a study which has shown that there is significant improvement in progression-free survival and overall survival in these cases. So the therapy part we can discuss in another webinar, and this we will limit to the different isotopes. Yeah, here is an example of alpha therapy where this is a bronchial carcinoid, and you can see that most of the lesions have disappeared. And actually, yeah, the theranostics is the one where you can diagnose with the same isotope and give the therapy, and this is the key actually to the treatment in these cancers. Here are examples where you see uptake in other tumors, the gallium dotaNOC uptake. This is a case of phosphaturic mesenchymal tumor in the nasal septum and multiple fractures in the ribs, and here in the right acetabulum, the proximal tibia on both sides. And here is a case of meningioma with high dotaNOC uptake. This was a radiation therapy planning scan. Before giving radiation therapy to this tumor, the oncologist wanted to make sure that it is a meningioma, so we had done this scan instead of a biopsy to see whether there is dotaNOC uptake. And meningiomas have somatostatin expression, and we did this scan to see to prove that it is a meningioma. And then the tumors, this is bilateral glomus, tumors in the jugular foramen. And another gallium labeled tracer we have is the RGD. RGD is arginine, glycine, and aspartate. This can be labeled with F18 also. This is an example of an F18 labeled RGD. Here the uptake is very, it's not, you can see that it's a very blurred image, but with gallium you get a better image, and it images the neovascularization because it targets the endothelial receptors, and the activated endothelial cells have expressed these receptors. It's not expressed in the quiescent endothelial cells. So the neovascularization is a hallmark of cancer growth, and this is targeted in these tumors. There you can see increased expression in the breast tumor and also in the small intestinal neuroendocrine tumor. Now the PSMA is prostate-specific membrane antigen. It is overexpressed in prostate cancer cells. This is the receptor which has an intracellular component, a transmembrane, and an extracellular component. Here are the areas where the PSMA and the fluoride-labeled isotopes are bound, and you can see that there is high uptake in a tumor in the prostate gland, and it has been proven that the biopsy also correlates well with the increased tracer uptake. Here the biopsy from areas 1, 2, and 3 was positive for prostate cancer, and you're seeing uptake in the same areas. And this is the milestones of PSMA. It was FDA approved in for imaging, and in 2012, and we have started lutetium therapy, and the fluoride labeling was done in 2021, and now we are using it widely in staging of prostate cancer as well as therapy. This is an example of a prostate cancer, and comparison with an FDG scan, you can see that there is very high uptake of PSMA in the prostate gland compared to FDG PET. And you can see that the uptake in sub-centimeter lymph nodes as well as small bone metastasis is also very high. This is our own case where there is an invasive carcinoma of the prostate and metastatic disease, retroperitoneal lymph node and skeletal metastasis. The disseminated skeletal metastasis, PSMA uptake is very high compared to the FDG uptake in the bone metastasis. And this is a comparison with an F18 bone scan. Here there is a lot of uptake in the degenerative changes in the vertebrae, the osteophytes, and also uptake in the metastasis in the rib, but the PSMA scan shows uptake only in the metastasis and does not show any uptake in the degenerative changes. And this is a response to anti-androgen therapy, and you can see that the nodal metastases have decreased, and the subsequent scan we can see the new lesions have appeared, and that makes the patient resistant to anti-androgen therapy. And this is a response to chemotherapy. we can see that the number of lesions have decreased compared to the staging scan. And like what we have seen with peptide receptor therapy with neuroendocrine tumor, in prostate also we have the PSMA therapy. When you label PSMA with 177 lutetium, we can see that the response is very good. And the Vision trial is a phase 3 clinical trial, which has shown that there is a significant improvement in progression-free and overall survival. The other tracer that is available now is FAPI. We can label this with fluoride as well as gallium. And gallium labeling is much simpler because of that chelator present. And FAPI is the fibroblast activation protein inhibitor. The cancer cell is associated with fibrostroma, which has an activated fibroblast. So these receptors are present on the fibroblast and not actually on the cancer cells. And the imaging targets these fibroblasts, and they are actually there is very low expression in the normal tissue and higher expression of these in the cancer cells, so they can be targeted for imaging. And this was an article which had shown increased FAPI uptake in most of the common cancers we see every day. And the labeling with of this ligand with beta emitting or an alpha emitting isotope opens door for a lot of therapies that we can do. And it overcomes the limitation of FDG, where we can image renal cell carcinoma and thyroid cancer also. So the cancers that have low FDG uptake have shown an increased uptake of FAPI. And this is an example of a metastatic carotid body tumor, and 3 scans were done: DOTA-TATE scan and the PSMA scan, which has shown very high uptake, and FAPI scan has shown a moderately increased uptake in the tumor. So the tumors can have a very heterogeneous nature. Some lesions can show less uptake, and some lesions can show high uptake. There can be higher PSMA uptake and higher FDG uptake. So it all depends on the heterogeneous nature of the tumor, and that is important when we are deciding any radionuclide therapy. This is a very interesting case which was published, a case of medullary carcinoma of thyroid, where there was a sudden this swelling was there for a long time in the patient, and sudden increase in size was seen, and it was evaluated as a medullary carcinoma thyroid. The patient had a total thyroidectomy, and after that the patient was there was very less FDG uptake in this tumor. So the patient was subjected for external radiation therapy. During radiation therapy, the tumor grew in size and with ulceration, and gallium DOTA-NOG scan was done, which showed very low uptake. And then the FAPI scan showed a high uptake in the tumor. So the patient was taken up for FAPI therapy, and you can see that there is a very good response after 1 cycle of FAPI therapy. And the uptake also has decreased compared to the previous scan. But then there was a metastatic deposit in the liver. So there was a heterogeneous response. And then another isotope that we have is the gallium labeled exendin-4 that targets the glucagon-like peptide, and it is used in diagnosis of insulinomas. This is an example where you can see that the enhancing lesion in the body of the pancreas shows high exendin uptake, whereas this enhancing lesion in the tail of the pancreas close to the splenic hilum, there is no uptake here. So this was a splenunculus, and this was an insulinoma. So in neuroendocrine tumors, we have a lot of targets, the receptors. You have the somatostatin receptor agonist, antagonist, the CCK2R, the FDOPA, and you have the fibroblast activated protein. And then the polydifferentiated neuroendocrine tumors have high FDG accumulation. And then you have the glucagon-like peptide, and its analog is exendin 4, and then you have the MIBG also, and these all can be targets of therapy as well. So in conclusion, I would like to say that the newer PET tracers are more specific, and they have overcome the limitation of FDG to a certain level. Although you don't, they're not 100% specific also, because we are seeing a lot of uptake in inflammation, especially in IgG4 disease and autoimmune and sarcoidosis. So still there is a lot of research to be done and to come up with a perfect tracer. These tracers target specific cancers, and then when you label them with beta emitting and alpha emitting isotopes, these peptides become a strong therapeutic agent, and they have shown that a good progression-free survival and overall survival in patients who have not responded to multiple chemotherapeutic agents and other treatment modalities. So this will be the end. Thank you very much.
All right. Yeah, thank you, Dr. Mansoor, for a beautiful presentation. Dr. Mansoor showed us the limitations of the FDG, which is most commonly done in the PET-CT investigation. After that, he told us about targeted isotopes, which are used for diagnosing various types of tumors. Sometimes they are pretty specific. And we can also diagnose the tumor of as small as 10 millimeter size, you said. And also, with these new tracers, there are new openings coming up in terms of radionuclide treatment, therapeutics. So thank you very much, Dr. Mansoor. Dr. Krishna Mohan, any questions for Dr. Mansoor? Any comments on his talk and any views?
Yes, sir. So, Dr. Mansoor, excellent short overview of whatever is available for at the present day for imaging. Is you showed everything. So, in clinic, what we routinely use, as I said, FDG PET is not the answer for everything. I think everybody understands now and agrees. And we are routinely using, apart from the FDG PET, we routinely use the DOTA PET for neuroendocrine tumors. And what happens sometimes is some patients, we ask both DOTA PET and FDG, especially in the neuroendocrine things. So many patients come back to us asking that, why are you asking for 2 scans? Then we will have to sit with them and then explain that the avidity of the tumor, and then the need to pick up the high grade and then low grade tumors, because this is for the benefit of everybody who's viewing, and it has got a lot of meaning in the treatment decision making. And I agree with you that we are on the learning curve, especially how to use these newer newer radiopharmaceuticals. And what, as a clinician, I want is some imaging, which is imaging modality, which is 100% specific and 100% sensitive, which is, of course, it's a dreamlike situation, but that's what we want. And for nuclear medicine, what I especially want is that that imaging, whatever we are doing it, that radiopharmaceutical should also be useful for the treatment. Like lutetium. Lutetium, I think it's a wonderful drug. Lutetium, when it is tagged with, we have a handful of patients whom we have been treating for the neuroendocrine tumors, the lutetium, the PRRT therapy, and then nowadays the PSMA, lutetium PSMA therapy, which we are doing. And definitely, yes, we are in very much exciting times, and we are happy to learn together. And I think almost any tumor board, multidisciplinary tumor board, is incomplete with a nuclear physician nowadays, especially in the cancer centers. Because imaging and radiologist is a must, who is always there. And like Professor Kakarla sir says, radiologist is the consultant of a consultant. So we always talk to the radiologist and discuss with them. Now nuclear medicine is also compulsory, a part of it, because we many times discuss what is the possibility, what is this possibility, and is there any additional chance of adding this lutetium therapy in these patients. So what is important from take home from your talk as a clinician is, so the F-DOPA, and of course we have been using it in pheochromocytomas. Being a cancer center, we see patients with pheochromas. But what I learned from your talk is that the utility of F-DOPA in the glioma recurrence, because it happens many times when brain tumors recur on a regular MRI with MR spec. Also, it may be difficult for us to differentiate between the necrosis or recurrence and something. And when we want to scale up our treatment, yes, I will definitely now take help of F-DOPA. And one thing, if somebody's lay people are viewing the age-old radio iodine imaging, the iodine imaging we do for the thyroid cancers and iodine therapy. So how is that different from the present day newer radio pharmaceuticals and radiopharmacy imaging? That one final word, if you can tell.
Yes, sir. The radioiodine therapy is mostly used in thyroid cancer, and if you label the radioiodine with MIBG, it is used in MIBG therapy as well. The lutetium therapy is also a beta emitting isotope, and that also has some gamma emission. You can do SPECT imaging with that, and with radioiodine also we can do SPECT imaging. But the main difference here is, of course, after the indication that one is used in one type of cancer and the other is used in the other type of cancer. Iodine therapy is given orally, and most of the time patient is isolated, and then the therapy is slow, and there is a good improvement after that. And of course, thyroid cancer is not a very aggressive cancer, but in neuroendocrine cancers, now lutetium therapy is given in mostly metastatic disease, so it's also given in cycles, but the response that we get with lutetium therapy is not as good as the response that we get in radioiodine therapy. But in future, when we use lutetium therapy in neuroendocrine tumors and prostates upfront, then maybe we will get a very good response in those cases when compared to the cases which are already been treated with a lot of chemotherapy and other therapies. So honestly speaking, my experience with lutetium therapy is very limited. I have good experience with radioiodine therapy. So that is one point I can say. And the iodine therapy is very simple, but in lutetium therapy there has to be a preparation. And whenever you do a lutetium therapy, you have to do a Dotonok scan and do an FDG scan, and you have to check the renal parameters and the hepatic function, and then we have to give the amino acid to protect the kidneys, amino acid infusion. So these things are not there in thyroid cancer.
Sure.
All right.
So,
So, yeah, go ahead, Dr. Shimon, please.
So Dr. Mansoor, so out of the newer pharmaceuticals which you have enlisted, so what all the things are readily available for the benefit of everyone?
The DOTA peptide octreotide analogs, so Dotanok, Dotatate, and Dotatalk, and the PSMA is available. FAPI is available, and FAPI therapy is still, we need more data on that. And we have the Xendin 4, we have RGD, and yeah, these are available, and FDOPA is available. We get a fortnight supply of FDOPA, and when more people start producing it, like especially in the city, if Indo-American starts producing it, then probably we'll have a weekly supply. So these are the available tracers with us.
Thank you.
Thank you, sir.
Right. So I can see that now when a cancer patient comes, probably the things are looking bright. As I said that when I was a young man at that time, cancer means nearly death. But now we do see patients surviving for much longer time. Dr. Krishna Mohan, one question for you. In your experience, what is the longest survivor cancer patient? How long?
Sir, chronic myeloid leukemia, CML patients I have seen surviving for 25 years. And with the advent of that, yes, sir, imatinib. So there are many patients in blood cancer, and there are patients who have been cured of Hodgkin's lymphoma and metastatic or even metastatic germ cell tumors, testicular, ovarian germ cell tumors. So these are the things which are generally known to be curable. So the specific question, I think what you wanted to ask is that previously, 5 years back, for example, stage 4 lung cancer is written off. Stage 4 lung cancer, the median survival is 6 months. But today we have targeted therapies for lung cancer, which are EML4 ALK, genetic mutation testing. ALK positive patients are living up to 7 years, 8 years with excellent therapies which are being available. Similarly, the neuroendocrine tumors, low-grade neuroendocrine tumors, in spite of them being the stage 4 metastatic, they are surviving for many years with the somatostatin analogs, and that is where we are using right now the nuclear medicine therapeutics. Once they fail these things, we are subjecting them for the BRRT therapies, and they are living longer. With the recent data of the NETTER-1 and subsequent follow-up, we are now convinced that the somatostatin analogs and the BRRT therapy can be combined, and we see a bright future for them also. So one answer to your question, longest survival in blood cancers like CML and lymphomas, cure is possible, and especially in childhood cancers. In adult cancers, cancers like lung cancer or where a particular targeted therapy is available, the survival is more than 5 years. And in the low grade cancers, which are like metastatic neuroendocrine cancers, prolonged life again, 15 years, 20 years is possible with sequential use of available medicines, whatever are there in the market.
Right. So things are much better now, and they are looking even brighter in the near future and the distant future also. And I hope that probably when Mansoor will become as old as I am, he may be able to say that we are almost near stage of conquering the most of the cancers.
Yes.
Right. So with these, and let me just see whether there are any other questions from anybody else. No, I don't see any questions from anybody else. So I thank Dr. Krishna Mohan for sparing your valuable time. And thank you, Dr. Mansoor, for such a nice and lucid and very, very informative presentation. I hope a lot of medical fraternity and even common public would have been benefited with this. So with this, we'll close the session, and thanks everybody.
Thank you, sir.
Thank you, sir.
Thank you.